What about, those were IL-13. Oscar just told us about IL-4 and 13. You can block both cytokines just with one molecule. And so what does IL-4 give you? We don't really know. Maybe it gives you more anti-itch and these other effects that Oscar was discussing. So let's look at those data. And Oscar nicely showed you how blocking IL-4 receptor alpha can block the signaling through both cytokine receptors, IL-4 and IL-13. And so the nice thing about dupilumab is that it's been the most patients ever treated in atopic dermatitis published. We actually have large populations published for a long period of time. I am not going to go through all these data. I'm just going to show you some of the key data to see if it works or not. And so this is EASI-75. So we looked at EASI-50 before. This is actually 75% improvement. This is a success endpoint. Did it reach this high bar? And so you can see here, no matter which dose you use, 300 every 2 weeks or 300 every week, about half of patients get EASI-75. This is 16 weeks of use with dupilumab. No difference between the doses. And this was a study without using topical steroids, so no topical steroids allowed. Okay? Now, they did a study using topical steroids. And if you use topical steroids, this is the same endpoint, the same time, you can get about a 20%, 10 to 20% increase of patients getting that. So it works better with topical steroids. Dupilumab, topical steroids, 70% of your patients are going to get EASI-75. Okay, but then patients say, well, what about the, 50% of patients didn't get EASI-75? Are these people not responding? Are they not responders? And I can just tell you from experience, I participated in the trials. I had 35 patients on the drug for 3 years. I have over 100 patients on the drug now. But I can tell you from those first 35 patients on drug for 3 years, not one of them came off. Now, I agree with these data. They're the same that I see in clinic. 50% of people get EASI-75. But I wanted the company to go look at, well, what about the patients who don't get IgA clear, almost clear? Are they not responding? Is this a different phenotype or endotype? Because none of my patients are coming off, so I don't really have non-responders. So I wanted them to look at the data, so they did. And so these are the patients with a global assessment of clear, almost clear versus not clear, almost clear. And I said, look at these patients and tell me what they're doing. What is their EASI score doing? And so I'll just show you the data. This is percent change from baseline EASI. You can look at any endpoint. In patients not achieving global assessment of 0 or 1, okay? They're still getting a 60% reduction in EASI score. This is without topical steroids. And so this helped confirm what I saw in clinic, and what I've been seeing in clinic is that pretty much everybody responds, but just not everybody gets clear. Half get clear, almost clear. And then you can continue this effect, this improvement, this EASI-75 outcome. It maintains effect, so it's a durable effect up to 52-week data that we've presented so far. So this is Chronos data. These were data presented in The Lancet by Dr. Blauvelt. You get a 70 to 80% reduction in EASI in both every week and every other week, and it maintains it through 52 weeks. Okay, long-term, nice, durable responses. That's the EASI score. Well, what about the itch? Of course, the itch, that also is very important for patients. 50% reduction, that's maintained through 52 weeks. And so this is my patient who had been on cyclosporin. I had him on interferon gamma, et cetera, And this is the type of patient that we had before, didn't have a job. This is the type of patient now after 3 years on dupilumab. And there's many other clinically relevant endpoints. I love the endpoint that improves with dupilumab of the anxiety and depression. So anxiety and depression scales really improve even within 16 weeks. So I really like these downstream effects of the disease and your ability to see those improve with this drug. I'm going to skip the IgE. I don't know how important it is anyway, but I'm going to skip these, but it does improve. I just want to get to safety. This is a it does reduce, the IG does reduce. I don't know if it's clinically relevant or not. So if you look at a meta-analysis of all the studies, if you know how to read these kind of meta-analysis plots, these forest plots, this is the summary statistic. If it sits on 1, there's no difference between dupilumab and placebo. So total AEs, no difference. Serious adverse events is actually reduced in the dupilumab group, which you can imagine. Your skin's getting better, you're going to have fewer of these serious adverse events. And there was another study that showed actually skin infections are reduced. This is a recent publication. This is the only side effect to really think about. I mean, of course, understand the drug, know the drug, but this is the most common thing you'll see. This is my most severe conjunctivitis patients. It happens in 10 to 15% of patients. Just be ready for it. It's usually mild to moderate, and I do not know what causes it. It's not infectious, it's not sight-threatening. It's usually mild to moderate, and it can go away even with continued treatment. I have patients who had it a year ago, and now they've gone 2 years, no conjunctivitis, no treatment. So we're still doing lots of studies to try to figure out why this is happening. I recommend lubricating eye drops. I use ophthalmology referral. So you can use topical steroids or topical calcineurin inhibitors or compounded tacrolimus ointment. And there's a recent paper by Andreas Wollenberg that gives you that recipe.